Now, the risks of breastfeeding for infants, of not breastfeeding for infants and mothers. So you can see the left-hand side, the infant, and the right-hand side, the mother. So there's a lot of risk factors, for example, for infants, diarrhea, gastroenteritis, enterocolitis, and SIDS, asthma, pneumonia, ear infections, and one of the biggies being childhood obesity and type 2 diabetes, childhood leukemia. And for the mother, one of the biggest thing is a retention of gestational weight gain. So I know a lot of moms want to desperately try to lose that weight after they give birth. So that's one of the strongest points where you say, okay, these are the risk factors. And one of the other things we see is postpartum depression. Although we now see it's antepartum depression is also greater compared to what we see postpartum depression. But that does help breastfeeding to decrease the risk of postpartum depression. And you see the metabolic syndrome, prediabetes, type 2 diabetes, perimenopausal breast cancer, ovarian cancer. So these are all the risk factors you could see could go up with not breastfeeding. So switching gears to the hospital. So in the hospital, of course, there are different hospitals have different protocols. But we do want to encourage breastfeeding within the first hour of life. I know a lot of you probably are in a hospital setting and a lot of them in a maybe private clinic setting. But I do normally talk to the patient, maybe the last visit, a lot of breastfeeding, but I do keep checking with the patients, asking, are you still up with breastfeeding? What are your plans for breastfeeding? So encouraging them before they actually are done with me for the last visit, which is pretty much like a 36, 37 weeks, because you never know, you kind of lose the mom after that if they go into early labor or they're being induced. So a good time to talk about breastfeeding is, I would say, 35, 36, or 35 to 37 weeks. So I would strongly encourage breastfeeding within the first hour of life, and for every hour for our first 4 hours. Feed on demand when possible, and also highly encourage the baby be put to the breast. The skin-to-skin contact actually kind of helps bond with the mom and the baby. And if the nursing is delayed, we highly encourage pumping the milk to establish milk supply and prevent engorgement. And I do talk about taking asking for a referral for lactation educator or in the hospital to ask for them so that they can come and help them by the bedside. And the hospitals do have breast pumps where they can actually help the moms out after they deliver. So now switching gears to type 1 diabetes and breastfeeding. So the breastfeeding protocol or the guidelines are the same for type 1 and type 2. When compared to a normal non-diabetic mom. Breastfeeding is highly encouraged, and a lactating woman with type 1 diabetes, you can see that they really experience erratic patterns of glucose control, which includes a lot of hypoglycemia. So you got to be, one of the strong things you really want to focus on, also talk about is hypoglycemia, because there's a lot of mobilization of sugars, which can put at risk the type 1 diabetics as severe hypoglycemia. But the maternal hypoglycemia across the board is associated with delayed lactogenesis. So it's really not if someone is on insulin or not on insulin, but just the maternal hypoglycemia is associated with delayed lactogenesis. So that's where we actually are stressing glucose control during pregnancy. And glycemic control, that's the reason we should give a lot of attention. Episodes of hypoglycemia does induce epinephrine release, which causes temporary decrease in milk production. Hypoglycemia is most likely to occur within an hour of breastfeeding, and that's when it is really important to measure the blood glucose. And I'm going to go over the goal, but it's recommended either a snack before or during breastfeeding. So making sure the importance to check the blood pressure or blood sugar is very important. So the recent research appears to support the role of exclusive breastfeeding in at least delaying the onset of type 1 diabetes in susceptible children. So when I'm talking about a snack, a snack can be 15 grams of carb and a serving of protein. I bet many of the dietitians have logged in, they know what I'm talking about, but the rest of you guys know too. A snack could be maybe like, a fruit with some, nuts, or like some crackers with cheese, but it has to be at least 15 grams of carb and a serving of protein, about 7 to 8 grams of protein, to avoid any kind of a hypoglycemia. So there might be a need, since there's going to be erratic patterns of glucose control during lactation for someone who's type 1, we'd see that there should be a need to adjust or eliminate nighttime basal insulin to avoid any kind of nocturnal hypoglycemia. So recommendation is to check the sugars at pre and post meal for type 1, so I'm talking about type 1, at bedtime and 2 to 3 a.m. You want to make sure the mom is not waking up, already really low and is not in a position to check the sugars. So I say when you're not in a position to check the sugars, you assume you're low, and you would have 15 grams of carb or whatever, depending on your sugars. Make sure that you're taking care of the hypoglycemic episode. The Sweet Success Guidelines to Care recommends 1 to 2 hour postprandial blood glucose level of 150 to 155 during the breastfeeding period. And the fasting or the pre-meal goal would be about 70 to 100. And it's kind of pretty much the same goal for type 2 as well. So the focus for type 1 is hypoglycemia. You really want to make sure that that's something that is taken care of. So coming to type 2 diabetes and breastfeeding. Breastfeeding is strongly encouraged for type 2 diabetes as well. The major concern for type 2 diabetes, patients with type 2 diabetes, is the use of oral hypoglycemic agents and their effects on breast milk. I know this is a hot topic. Everybody kind of asks a lot about it, and we have a lot of questions coming about, should we leave the patients on hypoglycemic agents, or should we even leave them through the pregnancy? And a typical pattern when we have patients coming with either metformin or any oral hypoglycemic agent is taken off after the first trimester. And then you kind of transition to insulin. So there's a lot of questions around whether they need to be on the medication. What do we do? And especially about breastfeeding. So I'm going to talk about that a little bit so that you get a clear idea of where we stand. So the blood glucose goal is pretty much the same for type 2s as the type 1. So it's recommended to check blood sugars at fasting, 1 to 2 hour postprandial, at bedtime, and an occasional 2 to 3 a.m., but highly recommended 2 to 3 a.m. for the type 1 diabetics. So for GDMs, I know we have a big population of GDMs other than the pre-existing. I would recommend testing blood sugar 4 times a day for 3 to 4 days, those who are with no insulin. I know probably every setting might have a different protocol, but from where I am working, or I would normally tell, if you're not on insulin, if you're diet control only, you can test your sugars when you go back home, maybe 3 to 4 days, the same way you're doing 4 times a day, fasting, an hour after breakfast, lunch, and dinner. And if those who are without insulin, and those who are on insulin during pregnancy, I recommend checking at least a couple of weeks, and then they do kind of remind them to go in for the 6 to 12 weeks of oral glucose tolerance test, and I know we also do the A1C testing, and that is when you really, and I tell them if your sugars are consistently going up, you can send us a message, but typically you see, they have questions about, am I going to be a diabetic? What is my sugar going to look? So there's a lot of, anxiety associated with that. So I typically, when the placenta is cut, the sugars, maternal sugars kind of drop to normal, but not all the time. By definition, it takes about 24 to 48 hours after you deliver for your sugars to drop to normal. Someone who's got C-section, who had C-section, probably it's going to take like about a couple of weeks because C-section is a trauma to the body. Stress increases sugars. So that is one thing to focus on, and I bet all of you probably get the same kind of questions as to what am I doing after that, what is my sugar going to look? So that is something that kind of puts them at peace when you say, especially for GDMs, it's temporary, but when you deliver, this is what it looks like. So now, avoiding maternal hypoglycemia. So if your blood sugars are less than 100 before feeding, take 15 grams of carb and 7 grams of protein. So it's for type 1, so type 2, or anybody for GDM, if they're experiencing symptoms of low, they might want to check the sugars, but definitely for a type 1, if you want to make sure that you check your sugars before you breastfeed, and appropriately take a snack if your sugars are less than 100. If your blood sugars are more less than 100 after breastfeeding, you consider adding 15 grams of carbs if insulin on board. And if before feeding, you want to make sure, it depends on what your numbers look like. So you have to kind of make sure that you're telling the mom, you need to be testing your sugars before or after, because there's a lot of sugar being mobilized, so the tendency for you to go is low sugar. And hypoglycemia causes, like I said, it's a repeat, causes the release of epinephrine, which causes temporary decrease in milk production. And there are a lot of other factors how the milk production can be interfered. I'm going to talk about that as we go along.